Thank you for your help taking our PCC MS students from entry-level students to practitioners through a psychologically safe debriefing model.
Let's go through, what do you think is wrong with this patient?
Exacerbation.
There's COPD exacerbation differentials here.
Respiratory distress,
Asthma.
or failure.
Asthma.
Your lung sounds.
Rachel, I want to hear a little more. You said respiratory distress versus failure. Yes, that's
I think I mean more respiratory failure. I think she was to that point.
okay. How do you differentiate respiratory distress versus failure? Okay, anybody want to help?
No efficient ventilation, air exchange, respiration. That's the one I was looking for.
Say it one more time, Matt.
I said no efficient respirations, no gas exchanges happening. And failure is how I kind of think of it.
So when you differentiate respiratory distress versus failure, altered mental status, compensated versus decompensated. Distress, is your patient compensated? Failure, are they decompensated? Okay, so just curious from this one, where do you classify your patient? Distress or failure? Failure, okay. Other differentials.
Like illness.
Okay, pneumonia. All right, so let's work through these now and decide what's what and what your top priority or top suspicion is here. What do you think?
COPD was day one because she's already got a history of it.
I hear several COPDs out there for history wise. Anybody have a different number one than COPD? Everybody's good with one for COPD. Number two, what's your number two? You're ordering respiratory failure. Okay, it's kind of broad to use respiratory failure because we're not really sure where in treatment pathway here, but we could put that as a possible two because that could be, this could still be respiratory failure, right? This could be respiratory failure. This could be respiratory failure. Any of these could fall into respiratory failure. So it's okay to have that here as a secondary. So let's take it out for, what's your number three then?
Upper respiratory infection.
Yeah.
Upper respiratory. Pneumonia.
So I hear a pneumonia versus an upper respiratory infection.
I'm a little bit torn because wasn't it like rails that were noted? And if it's upper respiratory, wouldn't you hear
Wheezes.
stridor?
Those wheezes.
It was it?
Yeah,
Oh.
wheezes is lower lobes.
There were wheezes.
Okay.
So if we're looking at upper respiratory versus where are we at for me number three?
Didn't we?
Yeah.
So maybe pneumonia.
I would say pneumonia for
Yeah.
second.
Okay, so I hear people here at pneumonia. Are we still at URI? I'm not sure where we're at here.
Did she have
Number three.
Did she have a fever?
I don't know.
I don't think she did.
What are you thinking there? Why do you ask if she had a fever, Meredith?
I mean, pneumonia usually presents with a fever, right? So
So what
Use this differential, rule in, rule out. Okay. So
respiratory
And-
infection.
was pneumonia, was, when you were listening to lung sounds, was it bilateral or was it one specific side?
He said bilateral, it was
And-
both.
Yeah, and pneumonia is usually one, so I probably would just go with upper respiratory infection for three.
Yeah, that's one.
three for URI over.
My, yeah.
I just I don't
get green phlegm coughed up from.
Yeah.
Yeah.
Very true.
And why? So why did you settle then on COPD over respiratory infection or respiratory failure, pneumonia, asthma? Why did you settle on COPD? What's your key difference there?
say, well, if she has a history of COPD emphysema, then it's very likely that this is just like an exacerbated experience.
That could lead to respiratory failure if not treated.
Right.
Because of the severity, and she's already been
And
intubated once, already had to go through this whole process.
Yeah.
So you know that's coming down the track, but it all started with
Right.
the COPD is the main underlying cause of that.
Okay.
Respiratory.
So from history gathering, I think is what I'm hearing largely is how you got to COPD over any of the rest of these.
You still have those same symptoms, the fever, the phlegm, the wheezing, the rails, like that's all a piece of COPD as well. Like
Could be part of this. So how did you rule pneumonia out then?
bilateral and not one-sided.
And no fever.
No fever.
Okay, so negative fever,
She did not have a fever.
negative,
It was 98.
Okay, I didn't
Yeah,
notice
98
that.
point.
bilateral. What do you think? I'm gonna throw a differential up here for you.
Oh,
Sepsis.
I guess if we were on that track with respiratory infection though. But she didn't have a fever.
Help me rule this in or out. Is a fever always required in sepsis?
No, you're supposed to have 3 or more.
What was her heart
So
rate?
she was altered, tachycardic,
Okay,
hypertensive, no fever.
Sepsis though is usually hypo.
hypotensive, but altered and tachycardic is 2 signs of
Mhm.
sepsis.
Mhm.
But
Yeah,
there was no
hypertensive.
hypotension.
How about pauses? What went well in your call? What did you like?
Your aggressive treatments
Hmm.
about getting CPAP started, and you asked her again, have you been on CPAP before and have you been intubated before?
Yeah.
Good history take.
History of intubation and what was. There you go.
I thought he did a really good job of actually getting down on the same level as the patient instead of standing over or like bending over to talk to him. He actually like came over to the side, squatted down.
Rapport.
Didn't yell just because I was an older patient. He was still very cool, calm, collected, gentle talking, very polite.
I liked the
No.
drug confirmation that, like, even though it is albuterol, like. You
All right, let's move over to our Delta side, folks. What do we want to do better next time we run a scenario? Whether it's specific to this call or whether it's something, maybe we had a malfunction with one thing or the other.
I need to get better about my history taking. And.
What do you mean?
More detailed. History taking, it's not just. Yeah, like the history of medications, all the medications, I kind of went through those, but I didn't ask how long she had been. Having the difficulty breathing and that.
And I don't know if you picked up on it, my altered state, or if it was baseline or normal, like.
Yeah, and I didn't
my
pick up
name.
that either, like, is there a history of dementia, is this her baseline mentation? That type of history stuff I skipped over.
So how can I think that's a great piece to highlight that one of the most important tools, really, what makes a medic is our ability to think and interpret the information that we get, and we can think better or make better decisions, I should say, when we have better information. So I think you're onto something here, that making sure that you have a good, thorough history is essential. How can we? What tool or mechanism can we use to make sure that you're able to get a more complete history? How can we remember to actually get a more thorough history in the future?
Actually, like you could write stuff down on the way to the call to remember, like before your mind is frazzled. Like write stuff down, like I need to ask these different points, or just have it pre-written out in your notebook ahead of time. While your mind is clear, and then just fill that out and
Take some notes
yeah.
before, during, and after.
I had a question about that, actually, and I know we ended up not going down the hole, but it was like you were starting to set up RSI in the house.
Mhm.
And then instead of doing that, we moved her into the ambulance into like a bumpy ride.
Yeah,
And like, why would you wanna RSI, like, what was your thought process?
that was just my, like, thinking out loud.
Tell me a little bit more about your thought process on medications that you gave, what medications you did give, what medications you didn't give, medications you could have given but didn't. Okay. Any other meds you can think of you might have considered? And I don't know for sure if it's in your protocols on Olathe. We definitely talked about it in class. In fact, we spent quite some time in class on this med. Yeah, MAG. Any thoughts? Anybody move towards the thought of MAG?
I didn't even think about it.
I thought about it, but like, I don't think it's in our protocol, so.
Well, everybody pull up your protocols real quick and look, just check.
Because of it is for adult using. Okay. And
So-
potentially epi,
Potentially epi,
depending on how, that, like, just following our protocol down.
yep,
You can consider it.
yep. What are your thoughts if you're gonna move down that epi thought process? What are your other considerations for that? I think that's a great thing to consider there and add to your list.